Alrighty, hi everyone. Thanks for joining this month's joint community practice between the Washington Health Care Facilities Community Practice and the Wash Circuit Riders Community Practice. We have an exciting webinar that touches on both communities, and we're really excited to hear from our speakers today. I just want to give a few announcements before we turn it over to our speakers. We will have a Q&A at the end, at which point you can do one of two things. You can raise your hand and you feel free to unmute and ask the speakers questions. You're also welcome, as many of you know, to drop your questions in the chat throughout the presentation, and we'll help triage those and get those answered from the speakers. So next slide, please. Save the date. Our next community of practice webinar is next month, July 9th at 9 a.m. Eastern. It will feature the Promise Consortium, hearing about environmental contamination and hand hygiene practice in healthcare facilities in Uganda. So that's a big consortium that has done a lot of really great work. We're really excited to hear about their work at the intersection of policy, programming, and practice. Um, I just want to let you know that we will be taking a break in August for both communities, and we'll be coming back strong in September with lots of exciting programming. In the meantime, please keep in touch. We have LinkedIn groups for both communities of practice. If you have questions, you can send us an email at either of these email accounts for either communities. Feel free to get in touch with Nikki and I as well. You can check out our websites. And if you're not in the Global Wash Circuit Riders directory, please let us know. We can get you added. That document is available on LinkedIn. If you join our LinkedIn group, you can access that document. It's behind sort of some protection, so it's not completely publicly available. I think that's all the announcements that we have for now. Lots of other exciting things coming up. I know many of you are aware of the Water and Health Conference coming up this fall. We're excited to announce that we will have a Circuit Rider community practice site event and a couple healthcare facility site events. So stay tuned for more information on that. If you'd like to get involved, please feel free to get in touch. But with that, I'll turn it over to our speakers and introduce Rachel and Bruce from Maji Safi. Rachel Stephen is the executive director of the Maji Safi Group, where she leads the organization's efforts to improve WASH, MHM, and hygiene, agriculture, nutrition, and community development across Tanzania. And Bruce co-founded Maji Safi Group in 2012, has had many different roles in the organization in both the US and in Tanzania, where he served as board member, secretary, director of operations, and lived and ran operations for 5 years. He Since 2015, he's been the president of Maji Safi Group, registered in Colorado. We will post the resources from the presentation today. If you'd like to learn more, there's several YouTubes and more resources available on the website. But with that, I will turn it over to Rachel and Bruce. Thanks so much for joining and being willing to present.
Thanks so much, Ryan, and for the invitation. It's always fun to present to the community the practice, and I've been part of these for many years. Maji Safi started in 2012 together with Max Pearl Slater, who actually was part of getting us involved in the Washington Healthcare Facilities community of practice when he was getting his MPH at Emory back during COVID times. And I'll turn this over to Rachel for most of it. I'm very excited about hearing her present. I was part of getting our Washington healthcare facility focus going in, early 2021, I believe is when we started this initiative, but she's been the one on the ground doing most of the work and most of the implementation. And good to see a lot of familiar faces on here. And I'll turn it over to you, Rachel.
Thank you, Bruce, and thank you, Ryan, for the introduction as well. And I'm happy to join you all for this short webinar today and share the work that we have been doing for the past 5-6 years here in Tanzania in the Mara region. Like Bruce said, we started Maji Safi Group in 2012, and our start was as a public outreach for the biggest hospital that we have here in Rorya. It's called Shirat KMT Hospital. And then later we were registered as a private entity, NGO, and started our operation. Our mission mostly is to ensure that we are reaching the most vulnerable communities around Tanzania and promote health and disease prevention. And we target mainly women and also youth. Next slide, please. Maji Safi Group operates in the, within 4 focus areas. The first one is menstrual health and school wash. And in this focus area, we do operate using various approaches. The first approach, we use school clubs, and we are operating in 6 districts within Mara region. And we form clubs of around 50 to 60 students, both girls and boys, and we take them through curriculum for 6 months, and afterwards the students go and transmit the knowledge into the larger school population. The second part, we do target parents and communities around. As we all know, menstrual hygiene and health touches culture, beliefs, and tradition of communities. So for it to be successfully, we also go back to parents and religious leaders who are mostly custodian of culture and beliefs within the communities. So we go to religious institutions through various women groups within the community and have discussion, breaking the silence around menstruations, so they can provide a friendly environment to support the young girls in schools. The second focus area is wash and healthcare facilities, which we will talk about it in details. But in the wash and healthcare facilities, we do around 4 approaches. So we work in infrastructure improvement. We work on around monitoring and evaluation, but we do also nutrition education to mothers of under 5, and we also do malnutrition screenings, and we do disease prevention education and technology demonstration to people who goes into healthcare facilities to get various services. But also within Washington healthcare facilities, we collaborate with both private-owned healthcare facilities as well as government-owned healthcare facilities. Our third focus area is information, communication, and technology. And here we target to reach the communities through various information medias. So we use our social media pages. We use various resources, writings, booklets, leaflets, to ensure that we give as much information to the people we are serving. But also we have a hotline services at our office. And when we go out into the community to outreaches or to healthcare facilities, and all our resources have the phone numbers that the community can find us for free, and they will receive the education we need. But also we call the community that we have met, and they still need more education on various WASH-related lessons. But also we do provide education through radios, and right now we are using 2 radios. One is a local radio targeting the Mara region, but the other one is a much larger radio, Free Africa, which reaches majority of Tanzania. And the fourth focus area is climate resilience WASH and agriculture, nutrition, and WASH. And in here, we are bringing together the wash aspect as well as agriculture and nutrition. Throughout our implementation and working in the Mara region and with the communities we serve, we have realized that sometimes they understand what needs to be changed, but they don't have the capacity to do so. So bringing in agriculture in there will help them improve their economic status, and they can afford majority of the things that we want to change in their households. So stuff like water filters, having improved latrines, and also for the nutrition part, because most people depend on agriculture, but they don't know how to properly use whatever they are already growing to improve nutrition in their families. So this is the area that we are bringing these two together and help the community reach its full potential, health-wise, as well as improving their economy. Next slide, please. Maji Safi Group, since its inception, we have tried to use and utilize community health educator model, and it has been working really well for the past 14 years that we have been working. Number one, it ensures that there is participatory community development in there, like community shares and participate in the changes that we want them to make. We recruit and train local women and youth that are from the areas we are implementing, that can speak the language, they can relate to majority of the issues that we want to change or educate the community, and they have that acceptability within the community, because they are people that they have trusted. And throughout, we have seen that this model ensures or helps in creating that sustainable change, because right now, Majisafi Group has become part and parcel of the community we are serving. They see us, or they see our community health educators as their service workers, so people who are really aiming to improve the community lives. And also through the community health educator model, we have seen many women being empowered, many youth being empowered. So now they have that capacity to go into public meetings, into larger groups of community, and provide education that the community needs. Next slide, please. And to go deeper into washing health care facilities, we decided to start working deeply into this area, because we realized it matters a lot. Many healthcare facilities have larger needs and very few resources. So we have seen that in the Mara region and Rorya district where we're working. Many healthcare facilities don't have access to clean and safe water. They don't have hygiene and sanitation education or practices around the facility, as well as waste management, both hard waste as well as the liquid waste as well. And through that, we have seen many water-related diseases, such as malaria, amoeba, and worms, increase, and some through the healthcare facilities as well. And generally, in Mara region, especially Rorya, because we live along the shore of Lake Victoria, there are many wash and water-related diseases. And so we decided to concentrate on this focus area so we can help reduce this burden, as well as all other healthcare associated infections. Another slide. And like I said initially, in the wash and healthcare facility components, we do work in infrastructure improvements, and in here we have targeted latrines or toilets, both for healthcare staff or workers, as well as for the patients, inpatients, and as well as outpatients. We have been working in improving waste management, so incinerators or burning chambers, as water systems, both boreholes as well as rainwater harvesting, and also water treatment and storage within healthcare facilities. We have been working in improving disease prevention. Like I said, we do have education sessions for the people that goes into healthcare facility to get various services. So we bring in disease prevention and wash education to them, and we showcase various technologies like filters, water treatment methods, hand washing technologies, as well as technologies for improving nutrition. And we do have nutrition education for mothers, caregivers, and the entire community around healthcare facilities. But also we do screening for the children who goes for mother and child clinics. And we collaborate this with Shirati KMT Hospital that have a larger nutrition program, and they provide supplement for kids with malnutrition. So our community health educators will do screening, and if a kid is showing signs of malnutrition, we'll refer them to KMT Hospital so they can get the support they need to improve their nutrition status. But we also demonstrate to mothers the way they can use local available foods to create nutritious meals for the under 5 children. And right now we have piloted a program where we bring the therapeutic supplement to the dispensary in the villages, and help the people and mothers who can't afford to travel, leave their family and come to a bigger hospital. So we bring the services to them. And another area we do for monitoring and evaluation is to strengthen the capacity and system within healthcare facility system in general. So we have trained our community health educators in data collection and monitoring, but we went further and trained healthcare officials for monitoring and evaluation using WashFit. Next slide. Like Bruce said, we decided to introduce the circuit rider approach in 2021. And the reason why we started using this was we knew there were needs, and through meetings with government officials, district officials, usually one common reason that came was we don't have enough resources. We don't have personnel resources. We don't have monetary resources to do to ensure that we do regular monitoring and maintenance to facilities. So we did a district-wide needs assessment across Rorya district to see how big is the need when it comes to wash and healthcare facilities. And out of that assessment, we realized 67% of facilities didn't have reliable source of water on site. Around 95 didn't have inclusive toilets. So they will have either one room or just 2 rooms that can be used like it's shown in the picture by everybody who attend the facility. And another thing was hand washing. Practices were very poor, and nearly 86% didn't have any form of hand washing structure in the facility. There were no gender segregated toilets. Drinking water was an issue, still an issue. Only one facility had access to drinking or mechanism for safe or reliable safe drinking water at the facility. And nearly all the facilities didn't have a dedicated budget for any improvements needed within the facility. So only three facilities reported that they had enough funding for when there are wash needs within the facility. Next slide, please. And as we were looking through those findings, we realized that even though there were more efforts through the government and other partners to improve infrastructures within healthcare facilities, the challenges were much larger, and most of that requires continuous technical support and capacity building, because some of the facilities had infrastructures prior, but just minor damages continued to grow, and in the end, the entire system collapsed. So you'll find a facility had a storage tank that started with the leaking, and then by the time we were visiting, the tank didn't work at all. So this showed us that infrastructures are needed, but also continuous technical support, monitoring, and also capacity strengthening will help. Next slide. So after the assessment, we decided to start the circuit rider approach. And we know, as many of you who have been working in the field knows, to work especially with the government-owned healthcare facilities, we needed a close collaboration with the government to ensure whatever we are starting will grow, will be sustainable, and will be adopted by the government. So we started to form close collaboration with the district health team or district health management teams, and also through the district medical office, where we will sit, go through the facilities and the findings, and choose which facilities has a pressing priority and start there. And through the challenges we identified and the priorities set, we started working slowly towards addressing the challenges. And our bigger aim is to ensure that district plans include wash budgets in them, and ensure that wash management or wash in healthcare facilities, so infrastructures monitoring, is part and parcel of their plans and budget. And we started initially with 11 healthcare facilities, and now we are working with 19 healthcare facilities. So we have 2 hospitals, 5 health centers, and 12 dispensaries. Next slide. And through the collaboration meetings and prioritization meetings that we have been having with the district, we have been able to support 5 healthcare facilities with full infrastructure construction projects. That means we have built latrines for the patients. We have worked on rainwater harvesting system or borehole, and also hand washing station or hand washing component, as well as the education part. We have been able to identify some of the improvement programs that were started by the government or the facility, but couldn't finish due to lack of funding. And so we worked together into ensuring we complete these. So 8 of the healthcare facilities, we did that approach. And for 6 facilities right now, we have worked together with the district and the facility, where we'll sit at the table, and then they will present their budgets and their needs, and then we invest in improving the needs or the infrastructure they need. So for some, the facility of the government, the district did toilets, maybe water systems, and then we did waste management. For some, they did other components, and then we did water systems. So we co-invest, and for that, we ensure that whatever infrastructures we have supported or we have built, it's owned by the district, it's owned by the facility, and we don't need to continue going back and supporting, improving that infrastructure. Next slide, please. As we were continuing working into improving the infrastructure, and through the close meetings we have been having with the district health management teams, we realized there are much larger needs into the quality of care beyond infrastructure, beyond wash, beyond monitoring. And we worked into identify the needs, and we found a good donor, Project Cure, and we worked into bringing medical equipment so they can support improving the care they receive from the hospitals. But also we have been training healthcare workers on nutrition screening, and also referral system, as well as provision of therapeutical food supplements. The work that our CHEs, community health educators, have been doing and continue to do, we make sure that stage by stage we do train healthcare workers so they can continue being part of the work, but also ensure sustainability if for some reason we cannot continue, and also if we want to expand to other places. Next slide. We have trained healthcare facility workers from the 19 facilities that we are working into wash fit, data collection and monitoring, implementation in general, and to make it more sustainable, because we work in one district, we ensure that whatever we are doing in Rorya district is taken into account into a larger wash and healthcare facility monitoring system nationwide. So we made sure our data is incorporated into the national system, and as the nation is continue to improve the monitoring and evaluation system and data collection system, our data is part and parcel of that. So we don't duplicate resources, and they don't need to come back as government to work within Rorya district, because whatever we are doing follows the guidelines and standard, and is incorporated in the government system. And right now we continue doing infrastructure support improvement needed to the 19 healthcare facility, as well as ongoing monthly visit collaboration with the facility. So when we go for monitoring and evaluation, we make sure the healthcare personnel that was trained is part of the team that is doing the monitoring and checking to ensure that the systems we have created continues to operate. Next slide. And we have, through the 5 years, we have learned a lot of lessons, because as we do or circuit riding, normally we started with our community health educators. So it will be 2 community health educators going to a facility and working into collecting the information, as well as providing technical support needed to that specific facility. And there were a lot of lessons that we have learned. Some stuff worked really well. Some needed adjustment as we continued, and we are still working on improving. And we have also had some few challenges. Next slide, Nikki. What has really worked well with us has been the use or the result of that strong collaboration that we have worked really well in forming with the district and facilities that we are working with. So as we go to these facilities, they treat us as partners, they treat us as a support needed to ensure that the work is done. And our community health educators have become technical agents of change into facilities. So through working into circuit riding, they have learned some of the technical support they can provide. So if there is a leakage there, what can they advise the facility to do? If the hand washing station is not working, what should be done? So this has been a really positive thing for Majisafi. And we have our motorcycles here that our community health educators use to ride into this facility, and has really helped us because we can go to even remote facilities using motorcycles, the facilities that are not easily accessible by a car. And it's a little bit cheaper to operate motorcycles. So cost-wise, it is cheaper. And using this model, we can showcase to the government that ensuring that monitoring and evaluation and continuous support to facilities doesn't need to be that expensive. But we have also continued to provide mentorship to facility staff and knowledge sharing among the staff under our community health educators. When we go, as I said, the teams work as one team, and within that, they learn from one another, they share, they improve, they provide suggestion on various approaches we can use and continue to improve to ensure that we are reaching the targets we have set, and we are serving the community as planned. And through the monthly visits or riding to facilities has been really key on identifying the needs before they became major challenges or major problems. So our community health educators will bring the immediate needs. And when we do have our meetings with district teams, we do discuss, we do share on how they can work on addressing them immediately before they become bigger problems that will require much more resources. Next slide, please. And again, as I said, it didn't go without challenges. And one of the challenge, which is the common challenge across, is government action towards identified needs or improvement needs. Most of the time, because of how long the processes are within the government, within the budget and approvals. It takes them a longer time to work on the issues, and sometimes those issues turn into bigger problems. In some areas, we still meet with the dependents. So you go, you work together, and then they sit and wait for Majisafi to come and solve the problems. So some areas we still have that challenge, and we continue working on that to ensure they understand some of the issues, especially if addressed early, they don't require external support or external funding. Another challenge we have been encountering is the staff turnover to healthcare facilities. So you do capacity building session, we continue doing mentoring, but then it's kind of every time. Some facilities have a very high turnover, so it seems as every day you are training and meeting new people, and that is a challenge because you move one step or two steps forward, and then you have to come back and have a training, a refresher, that has been a challenge as well. Another is limited resources to facilities, especially dispensaries, that sometimes they have one or two people, and it's not enough to work on improvements as well as treat people or provide the quality of service that is needed to the people, and they are overwhelmed. And even if you bring in external support that CHEs, still they have so much going on and they can't be part of the team. So it in few areas it becomes our CHEs will continue working on improvements and monitoring and evaluation, while the facility personnel is just overwhelmed and doing other stuff. Next slide. And also we have learned a lot, and we continue learning and improving. One thing we have learned is government ownership is essential for long-term sustainability. For like when I was saying, we started doing full constructions on the needs of the facility, and then we were like, most of the time they will term the infrastructure you have built as Majisafi Group toilet, and that means it's not part of the infrastructure. That means if a tap is broken, they call you, hey, the toilet you built, the tap is broken. And then we moved into the collaboration and co-investing. That means whatever we are building is much as theirs as ours, and most of the time we support, and then we are outside, be like, we are supporting, this is your infrastructure, this is your facility. And now it has been working really well. Monitoring and supportive supervision visits, they need to be regular as much as possible, and by increasing the frequency, we have seen good results. Another lesson we have learned is identifying the needs and challenges before they become bigger gaps or bigger problems is a very good way to reduce the cost of maintenance and repairs in facilities. And it has been working well. And nowadays we have seen facility appreciate the regular follow-ups and monitoring that we have been doing. And capacity building to facility personnel has really helped in building that dependence or interdependence. Like, they do work on their own problems, even if they come for external support. You can see now they have really thought the needs, they have made priorities, they have identified which resources they do have and what issues they will need external support. And another thing we have learned is the strong partnership that we have created and formed and continue to grow with the district has really improved the problem solving and accountability. Because even now, the district, when they do present the needs of the facility, again, they come with a proposal. Usually they will present, we need the ABCD, this can be covered by the district, this can be covered by the facility, and this will need Maji Safi group support. And for us, that is a very good progress towards improving ocean healthcare facilities. Next slide, please. What we are planning, or we are working right now to continue improving the model, is pairing our community health educators with local artisanal technicians. So we have been going as just Maji Safi staff, and we have been helping some of the technical needs, but we have realized that we need local technicians that can be partnered with the facility, and then the facility can just call that technician if there is a minor repair needed to that facility. So right now, we are working into that. We are also working into ensuring that the repair and maintenance are more frequent, like the way we do with the monitoring visits. And we are hoping, using the local technicians, we will improve this and showcase that it doesn't need to be expensive to hire a technician if you use a technician that is a community member where the facility is located. And we are also working into strengthening the monitoring post-construction, especially for the construction that we are supporting, as well as the larger government construction program that is going on in several facilities within Rorya district and Mara region in general. We want to ensure that they have that post-construction strategy built or in place as soon as they finish construction, because most of the time they will have a new facility, new infrastructure, and wait until it starts creating issues for them to start working on that strategy. And we are also moving in from infrastructure delivery to long-term service sustainability. So we want facilities to be in a position to continue providing the services that the community needs, and they have budget in place, they have plans in place that is mainstreamly year after year, and they can continue working towards improving quality of care throughout the facility. Next slide, Nick. And at that, I would welcome Bruce to take us through any question or any sharing and discussion you might have. Thank you so much.
Great. Thank you so much, Rachel and Bruce, for that really exciting presentation. We already have a number of questions coming in the chat, so let's go ahead and get started so we have enough time to get through as many as we can. So the first question we've got here is, how did you select your circuit riders? Who pays them? Have you done additional training for them? And then who pays for parts and supplies that they need for regular repairs? It's a lot of questions bundled into one.
Go ahead with that, Rachel.
Okay, so like I said, our circuit rider have been our community health educators. And our community health educators, we have recruited and trained, and they are fully employed with Majisafi. So they are full staff that have been employed with Majisafi. So Majisafi pays them. But we also partner them with healthcare facility staff. So they are government staff, they are paid through the government. And as for parts and the repairs needed, some repairs, minor repairs that they can do, they work together to do those repairs. And facilities do pay for some parts. And if they are bigger repairs, Majisafi will support, but also the district do support with the repairs.
Great.
Yeah, maybe just to add a little color, we've always had the community support fund that we have in our quarterly budget every year, because we always would have either schools coming with an issue or healthcare facilities. So we try to use that as when needed, but trying to get the government and the facilities to be able to cover it first is the first option, or doing a cost sharing, or if we're doing an infrastructural, if they can provide some of the simple building materials, that kind of stuff.
Mm-hmm. Great, thank you. Next question related to school sanitation infrastructure. Um, Obviously, school sanitation, hand washing facilities are essential for improving student health and creating a safe environment. What does functionality and sustainability look like year round? Are there any key measures that you use to look at to sustain the use of infrastructure, especially hand washing facilities? Do you have a sense of what functionality and sustainability looks like throughout the years, or are there any issues with that in school sanitation and hygiene?
We do have for school and school wash, we do use a three-star approach methodology to kind of track. And we normally have quarterly meetings for the school that we work with. So we will have, again, our approach is the same as Bruce said. Number one, we support when we can, but our first target is to ensure the government and the school take charge in improving. So we use the three-star approach to kind of measure where the school is every quarter, and we collect that data. We have the feedback meetings with the teachers and the district education officers and kind of discuss the ways to improve if one school is struggling and such.
But we don't have any sort of, monitoring system for the hand washing stations regularly.
Great, thank you. Next question, interesting one. Do you measure whether your interventions are reducing disease? Do you use any sort of do you use health facility records or household surveys or interviews? And have you happened to see any results in this area?
I can talk a bit to this in terms of, matching health facility records or household surveys. We haven't done a lot of that. But from I think it was 16 to about 2020, we did a 5-year health screening program. So every summer we would test about 5,000 people in the community. Half of them were our participants and half of them were non-participants. So we basically set up mobile labs. We were mostly testing for amoebas, worms, and schistosomiasis. So all of those health screening reports can be found on our website on our resources pages, but we did see significant drops in disease rates year over year among our participants, as well as their family members. And that was kind of, one of the big initiatives we wanted to do to try to answer the question, which is the best question: is this actually reducing disease? Is this actually helping But I think we want to do a larger evaluation, especially Rachel touched on it, but um, I think it was April last year, we brought two Project Cure containers full of medical supplies, which has a equivalent value of about $1 million to the district. So doing a big follow up, and that's part of why, you know, we were really happy about the circuit rider system being in place because it could also be used to monitor, the functionality and making sure all of the machines work that we brought over. Project Cure does a great job of making sure, they're testing what the electricity um, at the dispensary or the health center is, and they provide you with the different transformers you need in order to make sure that you're not bringing over equipment that won't fit or that the healthcare facility doesn't have the expertise to use. But I think that was a really big initiative within our Washington healthcare facility program, and clearly the government really, really liked that piece as well because it's hard to do the job that you're supposed to do if you don't have the resources or the equipment, and especially for the secondary and tertiary facilities, even a good bed and some very simple equipment can be a huge improvement to what
Mhm.
the services they're able to provide.
Thanks, Bruce. I want to tie this to another question that came in. I had the same Maggie Montgomery had I had the same question as her as well. How do you work to integrate your circuit rider work with sort of district healthcare worker efforts? And specifically, the thing I'm really curious about is what does it look like to convince governments to add WASH to district budgets or to integrate circuit riding within programming? What information, data, et cetera, did they need to see that this is valuable and to sort of own a lot of these processes in your experience? I'd be curious to hear others' experiences elsewhere if there's other responses.
Rachel, would you like
Yes.
take that one?
Yes. So the way we started working was um, working around the need they were presenting to us. So normally the government will come to NGOs with the need for improvement, for monitoring, support us with fuel so we can go visit facilities and do supportive supervision to those. So we use the same when we have our meetings and kind of be like, uh, this is what can be done when you leave the issues to become bigger problems. And this is what we have been able to do with these much resources. So we started with initial meetings and we continue showing how we implement using the low cost that we have been using. So using motorcycles, using teams that have both maybe one outsider and the people from the facilities or facility to kind of do monitoring and showcase them. It doesn't need to be a huge budget. And also having a smaller budget in their annual budget for maintenance, just taking that into consideration helps into working with smaller issues before they become minor. So if you have because we all know government systems can be very difficult if you don't have that line budget in your annual budget. So having $50 in your budget for maintenance can help ensure that your water system is maintained before it breaks down. So we have been kind of using that and forming these collaboration teams and sitting together, sharing, being open on the cost we are using and the approaches we are using. That has been working.
And maybe a few more things. The government was also, there was a World Bank grant that the districts were able to apply for, and it was kind of a pay as you perform type thing. So if you could show that you were doing a good job in one fiscal year, then the next fiscal year you could apply for more
Mhm.
Washington healthcare facility funding. So we worked closely on that, making sure that we weren't, doubling up on projects or how we could, you know, convincing them to show that by making sure and being able to show the World Bank that these projects are being successful, then you're actually, able to apply for more the following year. And I think it also goes on top of the close relationship we built during those 5 years of health screenings. We would hire local lab technicians from the different hospitals, and had a very close relationship with the district medical and district health offices going into it as well.
Great, thank you. We have so many good questions, and we don't have enough time to get through them all. Maybe let's do one more. Um, the last question I'll ask is, are any of your data integrated with other national systems? I know this is a challenge in other country offices. So say WashFit, is that integrated with any sort of HMIS or other national level or district level data collection systems? How did government end up
So
getting?
we actually brought the national trainer on Wash Fit from the Ministry of Health up
Mhm.
to the Sharadi to do a training for the district office or district officials, as well as the different healthcare facilities, as well as different NGOs, stakeholders, civil society stakeholders, and that was the key step in getting integrated into the national system within the Ministry of Health and the district. I think, Rachel, how many districts are in that system in Tanzania right now? It's only a handful, right?
Yes, I'm not sure exactly how many, but they did, because the government has the Washington healthcare guideline, and they did their trainings. And so when we reached out and be like, we are working with the Circuit Rider Washington Healthcare Facility, and we want the data that we are collecting to contribute to the national efforts, they gave us the condition, like Bruce said, that for the nation to be able to consider that data, we need to train your people according to our standards. So they brought in the ministry trainer, and he facilitated the training, and they gave us access to enter data, to collect the data in there, as well as track our data from Rorya district. And for now, currently, then the ministry uses Kobo collect tool, but they are in a process of moving them toward the more centralized system. And so our data will be part of that going forward.
Great. Thank you so much. We are out of time. So many great questions. We'll see if we can find a way to get those answered. Thank you all for joining. Thanks for making this an engaging discussion. Uh, both to Bruce and Rachel for all your exciting insights, and for everyone who joined asking such great questions. So again, please feel free to reach out if you'd like to join any of our technical working groups. Don't forget our next webinar for healthcare facilities on July 9th. Feel free to go ahead and register for that. You'll get an in-calendar invite so that you don't forget to join. But thank you all. Have a good rest of your day, and we look forward to seeing you all soon. Take care.
Thank you all.